The time for introduce next speaker, Dr. Deepthi Madhu. She is the ICO Apollo Ablas Hospital, Kochi. She is more than 8 years of experience in healthcare sector. Management degree also he has. He has completed MD microbiology from PSG Coimbatore, and she has that international two credential. So one is the CPHQ and another is the CIC infection control. So her area of interest is infection control in high risk settings, diagnostics and antimicrobial stewardship, medication safety, and FMEA and mycology. So welcome, ma'am.
Thank you so much for the invitation, and thank you so much for including me in this CQE, wonderfully well thought out schedule ahead of the day. So without much further introduction, we'll come to this. I'll take you through my topic, post-exposure prophylaxis, specifically to hepatitis B and C, myself, Dr. Deepthi Madhu. So when we talk about post-exposure prophylaxis, it is a very tricky situation, as in the person is already exposed and you have a clear idea of what pathogen, or that you have a clear idea that you're dealing with a pathogen and you're handling the responsibility of giving them adequate coverage to the best of what medical scientific guidelines advise us to. For the same reason, it is very important to adhere to reliable, updated guidelines. So in this CQE, in this webinar, we'll be dealing with the most updated guidelines as of day, emphasis to that, because scientific evidence and research, everything R&D is continuously evolving. So there will be updations in the guidelines, and it is important that we keep ourselves updated to the day when it comes to post-exposure prophylaxis. In the case of HIV post-exposure prophylaxis, it is less of a gray area because NACO gives us very clear guidelines on it, and it is mandatory that we follow it. When it comes to hepatitis B and hepatitis C post-exposure prophylaxis, I have found CDC guidelines and CDC data to be very reliable because they give, one, it is regularly updated. Second, it comes with what, when, why, how. So that is what I have referred to mostly for furnishing the information in this session. Beginning with what is post-exposure prophylaxis. PEP is a terminology that we routinely use in association with HIV and rabies, but we have to understand that post-exposure prophylaxis is a general terminology, and in the definition, it does not refer to any single pathogen. So post-exposure prophylaxis, or also known as post-exposure prevention, PEP, is any preventive medical treatment started after exposure to an infectious agent in order to prevent the infection from developing in the exposed person. So that is post-exposure prophylaxis. In our healthcare setting and in infection control, we mostly refer to PEP among of healthcare workers, because in the line of work, they get exposed to a lot of infections. But PEP as a terminology does not restrict itself to healthcare workers alone. PEP, when it comes to rabies, is exposure of any person to that pathogen. So let us keep our fact straight. The fact straight that post-exposure prophylaxis is preventive treatment started after exposure to a particular infectious agent in order to prevent the infection from developing in the exposed person, irrespective of who that person is. Now, how to assess? How do we know that in a particular setting post-exposure prophylaxis is indicated? Because that is a million-dollar question, whether or not post-exposure prophylaxis is required. Once we have an answer to that, the rest of it falls in place relatively quickly. So what we need to understand here is the most important requirement, or the first thing that we need to look at, is the source. If the source is not infected, or if it is not a positive source, it doesn't matter what the immune status of the exposed person is, what the protection status of the exposed person is, it does not matter. So the source status is the single most important factor that we need to consider in order to evaluate whether post-exposure prophylaxis is required. So if it is a positive source, or if it is an infectious source, then we look at the next element. what is the status of the person who has been exposed, is if the exposed person is susceptible or not. If it is a positive source and the person is not susceptible, then there is no need for PEP, because the source is positive but the person is not susceptible. The person has immunity which confers protection against that particular pathogen. No need of post exposure prophylaxis. If it is a positive source and then the exposed person is susceptible, that is when we talk about post exposure prophylaxis. So two important requirements: a positive source and a susceptible exposed person, and then we trigger the post exposure prophylaxis sequence or the sequence of events. Now, coming to the two viruses or the two exposures that we are talking about in this session, one is hepatitis B, second is hepatitis C. So we'll take up hepatitis B first. In this case, when we talk about positive source or high risk exposure, what is it? It is basically, you have to know when you call a source as positive. At the end of the day, when we deal with a finicky situation, uh, if you don't have a clear idea of what exactly a positive source is, it can lead to panic and delay in service provision. When it comes to post exposure prophylaxis, we need to move in a time bound manner. So when the source is hepatitis B surface antigen positive, it does not matter what the rest of the serological markers are. If the source is hepatitis B surface antigen positive, and if possible, it is good to check for quantitative or qualitative PCR. When either of these is positive, you think of it, or you consider it as a positive source, and the first tick in the post exposure prophylaxis is in place. Next, we look at whether the healthcare provider is susceptible or not. So, who is a healthcare provider? A person who is susceptible where hepatitis B is concerned. It can be an unvaccinated person or a vaccinated person with inadequate titer. Now, that is the million dollar question. What is an adequate titer or what is an inadequate titer? So coming to anti-HPS titer. Anti-HPS titer of more than 10 milli international unit per ml indicates adequate protective status. Again, it is good to have, it is very important to have reliable guidelines that you can bang on. So anti-HPS titer more than 10 milli international unit per ml indicates adequate protective status. Now, the second point is, irrespective of vaccination status, whether the person has been given two entire doses of entire series of vaccine, whether it is a person who has received only two doses of vaccine, it does not matter what the vaccination status is. If you have a titer value and the titer value is more than 10 MIU, then we can consider the person as having adequate protection. Now, interpretation of anti-HPS titers is also a very, considered as it's an area, it's a minefield. If you don't interpret it correctly, it can lead to a lot of confusions and delay in provisional services, as I said earlier. So, anti-HPS titer, there are different institutions which have different policies on how to and when to check anti-HPS titers. So, if you are checking anti-HPS titer 4 to 6 weeks after last HPV vaccination, please do not check anti-HPS titer immediately after the last dose. Please don't make that mistake. And please don't check hepatitis B surface antigen also immediately after vaccination, because post-vaccination, immediately if you check, you may get a false positive. So 4 to 6 weeks after last HPV vaccination, less than 10 IU per liter, HPV vaccine non-responder, probably no HPV protection. So in this case, you may have to go ahead with the whole repeated series of vaccination, again 016. So maybe a non-responder. More than or equal to 10, immune lifelong protection against clinical HPV infection. More than 100 IU, immune lifelong protection against clinical HPV infection, minimal risk of HPV carrier rate. So this is 4 to 6 weeks after last HPV vaccination. Now, if it is months to years after last HPV vaccination, you have less than 10, although chance of protection is there, there is no documented evidence that the person is protected. HPV protection remains uncertain, but there remains a chance that the person will respond if at all there is a trigger or a response. If there's a trigger or a exposure, there is a good chance that the person will respond because his immune system might respond to it, but protection is uncertain. If it is more than 10, immune lifelong protection against clinical HPV infection. Again, the question can come here, arise here regarding booster dose. See, if it is a person who has, in this particular table, we have mentioned lifelong protection, because once the person's titer has gone beyond 10, his immune system is primed. Later on in life, if at all his titer has dipped to say 8 or 9, and he is exposed to hepatitis B virus, his immune system will respond. It will be triggered. The exposure itself can act as a booster, and it will trigger the immune system to produce antibodies. Hence, the derivative conclusion that once adequate titer is attained, it assures more or less that lifelong protection is there, but there is definitely no harm in taking a booster dose. There is no harm at all in taking booster doses. Now, we have a positive source and we have a susceptible healthcare provider or a susceptible exposed person. What do you do? That is the situation where we come to discuss the post-exposure prophylaxis specific for it. Persons who have adequate anti-HBs titer do not require any further protective intervention. Persons who have written documentation of a complete hepatitis B vaccine series and who did not receive post-vaccination testing should receive a single vaccine booster dose. Now, we are talking about a person who has completed vaccination, 3 doses. He has the vaccination employee card or his vaccination certificate is there with them. Now it is a question of reliable or responsible utilization of resources. You have a person who has sustained exposure to a positive hepatitis B source, and that person has completed 3 doses of vaccine. If you choose to check anti-HBs titer, it is a good thing. But is it a good way of utilizing your limited resources if you are in a resource limited setting? Because anti-HBs titer has its own financial implications. On the other hand, you have the option of giving a single booster dose to get the body to respond sooner and produce more antibodies faster. So that comes with a less or a lower financial implication. So if you are in a resource limited setting, you can go directly for a booster dose. And if you are not, in a resource limited setting, please go ahead with the anti-HBs titer value. And based on the titer value, you can decide whether or not a booster dose is required. Now, unvaccinated persons should receive hepatitis B vaccine as soon as possible after exposure, and the hepatitis B vaccine series should be completed in accordance with age appropriate vaccine dose and schedule. Now we come to hepatitis C. Now the challenges that we face when it comes to hepatitis C is a little different from the challenge that we face in hepatitis B, because in hepatitis C, the source status confirmation itself is a gray area. We need to have a clear idea of what a positive source is, because the screening test is anti-HCV antibody. We test for anti-HCV antibody, and that is the screening test, and the confirmatory test is RNA. There are different permutations and combinations of these two tests and how to interpret it. Based on your interpretation, your source status code or your source status is determined. And if it goes wrong, the rest of your management can also go wrong. So HCV antibody, if it is non-reactive, sample can be reported as non-reactive, nothing to be done, no further action required. If HCV antibody is reactive, it is a presumptive HCV infection. It is presumptive, not confirmed. That test is confirmed, but it is not a confirmatory test, it is a screening test. So when the third column says, third row says, HCV antibody is reactive and HCV RNA is detected, that is current HCV infection. And this is where we talk about, the actual exposure has happened. This is where we require action and follow up, and we need to trigger our responses. The fourth one, the most gray area, HCV antibody is reactive, HCV RNA not detected. No current HCV infection. This is where you can make or break the situation. In most cases, no further action is required. If distinction between true positivity and biological positivity for HCV antibody is desired, and if sample is repeatedly reactive in the initial test, test with another HCV antibody assay. Choose for another methodology, test for the same parameter HCV antibody. In certain situations, follow up with HCV RNA testing and appropriate counseling. In if it is a situation where HCV antibody is reactive and HCV RNA is not detected, based on the clinical profile of the source, based on the clinical history of the source, you can come to a conclusion whether or not to follow up, whether or not it requires to be a case that exposure that needs to be, that warrants to be followed up, or if clinical history is not available, to be on the safe side, it is good to follow up. So in this is current HCV infection. So if it is HCV antibody and if it is positive, that is the right part of the slide. It is reactive. Then you test for HCV RNA. If it is detected, then it is current HCV infection and we have to link to care. If the HCV antibody is reactive, HCV RNA is not detected, no current HCV infection, additional testing as appropriate. Please do factor in clinical profile and clinical history of the patient. If HCV antibody is non-reactive, then no HCV antibody is detected, no further cascade initiated. So that is testing the source. So we have determined whether or not the source is positive, whether an exposure has actually happened. Now we come to testing the exposed provider. In this case, because HCV is not a disease, HCV is not a pathogen for which we have any vaccination at hand. So it is very important that we do a baseline serologic profile of the exposed person. So initially test healthcare provider for anti-HCV, baseline anti-HCV positive and HCV RNA positive. This has also happened. So there have been situations where I have thanked my lucky stars that I did a baseline serology and realized that the person is already HCV positive. Otherwise, if we had not done the baseline serology, 3 or 4 weeks or months down the lane, we'll be breaking our head over a seroconversion, probable seroconversion. So it is very important to have a baseline serology. In the other hand, on the right side of the diagram, we have baseline anti-HCV negative or baseline anti-HCV positive with the negative RNA. In such cases, we do NAT for HCV RNA, that is nucleic acid test for HCV RNA 3 to 6 weeks after exposure. If it is detected, refer to care. If HCV RNA is not detected, then test for anti-HCV with HCV RNA test at 4 to 6 months after exposure. Again, if it is at 4 to 6 months, if HCV RNA becomes positive in an earlier negative patient, then it is seroconversion and we have to immediately initiate care. If anti-HCV is negative even after 4 to 6 months, we can stop the follow-up and further interventions can be safely assumed to be not required. So if the healthcare provider is HCV RNA negative at 3 to 6 weeks, test one more time at 4 to 6 months after exposure for HCV antibody with reflex to RNA if positive. If HCP remains, that is the healthcare provider remains anti-HCV negative at 4 to 6 months, no follow-up is needed in most circumstances. If at any point the healthcare provider has detectable HCV RNA or test positive for anti-HCV after a previous negative test, document seroconversion and initiate treatment. Now, in post-exposure prophylaxis for HCV, CDC does not recommend HCV PEP with direct acting antiviral therapy for all potential exposures. The effectiveness and duration of treatment that would be required have not been established. So this is still in the pipeline. Eventually, we can expect this to be happening. That's the note on which we began the session. It is important to have continuous updated information on the topic. So as of now, the effectiveness and duration of treatment has not been established, so it is on hold. However, the good news is the risk of transmission of HCV from percutaneous exposures is 0.2% and mucocutaneous exposure is low, very close to 1%. Further, routine post-exposure prophylaxis used for all occupational percutaneous exposures would treat approximately 1,000 HCV exposed individuals for every 2 who might become infected. So with that, I wind up the session. Thank you so much for your patient listening. I hope I have alleviated some of the long-standing concerns as Dr. Anoop had said at the beginning of the session. Thank you so much.